Joining me now are Dr. Lane Roland and Pam Cooper. Dr. Roland is an assistant professor and director of imaging intervention at the Brown Cancer Center. Pam Cooper is a registered nurse and project coordinator for the Partnership in Cancer Control. Dr. Roland and Pam, welcome to Health Matters.
Thank you.
Dr. Roland, let's start with the basics. What exactly is breast cancer, and what are the various forms of breast cancer?
Breast cancer is a malignant tumor of the breast. There's an invasive form of breast cancer called invasive ductal carcinoma, which accounts for about 80% of the cancers that we see. There's also an invasive lobular cancer, which accounts for about 10%, as well as a ductal carcinoma in situ, which is an earlier type of cancer where it's still inside the duct and it hasn't spread outside. Mm-hmm. There are also some various specialty rarer types of cancer, with the most rare being inflammatory at 1%.
I've heard a lot about inflammatory breast cancer of late. It seems to be...
You hear a lot about it.
Yeah.
Thankfully, it's very rare. It is a bad cancer to get, but we are learning more about it, and it is still treated.
But how common in general is breast cancer?
Breast cancer itself is extraordinarily common. 1 in every 8 women over the total population. In other words, your risk increases as you age, but it's about 12.5 to 13%.
Mm-hmm. And risk factors, what are the things that make people more at risk for breast cancer?
Risk factors are, first and foremost, being a woman and growing older. That's about all it takes. Mm-hmm. Men do get breast cancer, but that's only about 1% of what we see. Thankfully, hereditary breast cancer is only about 10 to 12% of what we see, and those are linked with what's called a BRCA1 or BRCA2 mutation. So those are rare. Other things that slightly increase your risk are your unopposed estrogen, as far as early menarche, late menopause, hormone replacement therapy, things like that. First pregnancy after 30 or no children. Mm-hmm. Other things that can increase your risk slightly: dense breasts, alcohol use. Very little alcohol use can increase your risk slightly.
Yeah, I've often heard about studies that talk about the relationship between the fatty diets and
yes.
Is that considered a risk factor as well?
Your BMI or weight and obesity is also a risk factor. They say as little as 20 pounds of excess weight in a woman, particularly around the midsection, increases risk slightly. So
we're going through a period where we're identifying an epidemic of obesity. Is that going to signal a potential increase in rise in breast cancer incidence?
I think it's going to signal a rise in lots of illnesses, more importantly heart disease and diabetes, and perhaps a slight increase in breast cancer.
Let's talk about the detection for a minute. How do you detect breast cancer, and why is early detection, or is early detection important?
Early detection is essential. It's been proven with the nurses cohort study and multiple additional studies that early detection decreases mortality. So you're going to survive, and your prognosis is going to be much better. The reason being, early detection catches cancers before you can feel them when they're small. Mm-hmm. Smaller size equals earlier stage equals better prognosis.
And I know that there are many different ways to detect breast cancer. Could you speak to us about the different screening methodologies, if you will?
First and foremost, the gold standard is still conventional mammography. We're doing that today with digital mammography, but mammography remains the gold standard, simply because we can see it about 90+% of cancers before people can feel them.
Mm-hmm. Are there others? To talk about MRI or some other methodology?
MRI has certainly been in the news. New York Times, Christina Applegate, things like that have brought it to the forefront. Current guidelines for MRI, as recommended by the American Cancer Society in 2007, are as follows. It is not recommended for general population screening. Mm-hmm. It is recommended for those women at significantly increased risk, any woman that has a known BRCA1 or BRCA2 mutation, a woman that has a family member with a mutation but has not been tested herself, and women that are increased risk by genetic counseling or assessment of greater than 20 to 25%, as well as women that have received radiation between the ages of 10 and 30 for things like Hodgkin's lymphoma, and then there are a few rare genetic conditions.
Now, I know when I was trained, we were told that self-breast exam was a valuable part of the regimen. And recently there's been some discussion or quote-unquote research that says that that's problematic. Can you talk to us a little bit about that?
Right. The Cochrane Library came out and they reviewed a study done predominantly in China and Russia on about 400,000 women, saying that they could not find a link to decreased mortality, which is our goal with screening, of course, to catch things early and improve prognosis. However, this research was not done here. The way they treat palpable areas of concern and breast exam is a little bit different. Clinical breast exam is a personal choice for a woman. It is not a bad thing. We don't chastise women that don't do it, but I'm happy to encourage or show women how to do it. I think there's still a role for it, even if it's just the fact that it makes women more aware of their body and their own health.
Mm-hmm. And screening mammography, when should it start? How often should it be done?
Screening mammography starts for every woman beginning at age 40 and every year thereafter, just on an annual basis, with the exception of if a woman has a first-degree relative, a mother or a sister. We start 10 years prior to their diagnosis down to age 25. If a woman has one of the higher risks that we talked about, one of the genetic mutations, we begin screening with MRI and annual mammography age 25 to 30.
So if anyone needs more information, they certainly should talk to their physician or call the Brown Cancer Center. I'm sure that you have information available.
Yes, yes.
So Pam, I see that you're dying to get in the conversation. Let me ask you about can you tell us about the Partnership for Cancer Control and the work that your organization's been doing?
Thank you. Yes, the Louisville-Jefferson County Partnership in Cancer Control is a breast cancer coalition here in Jefferson County that serves as the arm of the Kentucky Women's Cancer Screening Program, which is the program for uninsured and underinsured women out of the Kentucky Department for Public Health. We screen about 4,000 women here in Jefferson County every year. It is an early detection program, we would like to say that. And there's two very important components to the partnership. One is a stationary clinic component, which involves the family health centers and also the Adewale community health centers. And then there is a community program with the mobile mammography van. And we screen many women out in the community at churches and civic organizations, community centers. We have a lot of people calling for those mobile van services.
So your program offers free or reduced cost mammography to those in need?
Yes, this is a low-income, income-eligible program, again through the Kentucky Department for Public Health. And I would be glad to speak with any of the women about whether they are eligible for the program.
What determines eligibility, just briefly?
Eligibility is determined by age and income for the partnership itself.
Mm-hmm. So now I've seen the mobile unit around town. I'm sure everybody has seen it. How can people access services from the Partnership for Cancer Control?
I would be glad to speak with anyone about the partnership. You can call me at the Brown Cancer Center at 852-8020. Or there are lists of where the mobile mammography will be on the Brown Cancer Center website, as well as the American Cancer Center website. And you know, we would be glad to talk with anybody about that.
So needless to say, this is potentially life-saving information that you're presenting with us today, and I hope that people are listening and will take advantage of that phone number again, which is?
852-8020.
So Dr. Roland and Pam Cooper, I want to thank you very much for being on Health Matters. We'll see you again, I'm sure.
Thank you.